This is an ultrasound study of a patient with a history of PO, nausea, vomiting for the last few days. What you are seeing is the longitudinal section of the left lobe of the liver, and this is the liver, this is the outer surface of the liver, sharp liver angle, raised echogenicity, no coarseness. This is the portal vein, and this is the inferior vena cava. This is the caudate lobe or segment 1 of the liver being bounded by a curved linear structure that is called the ligamentum venosum. So this is the ligamentum venosum, which is filled with fluid, and there is with dependent region echogenic, low level echogenic settled area within it. So this is the primary pathology that now one of the pathologies rather. It measures approximately 6.6 into 4.5 centimeters, and it's a cystic mass relating to the left lobe of the liver, segment 1, or the caudate lobe of the liver. As we know that the caudate lobe is bounded anteriorly by the ligamentum venosum, and the IVC course is posterior to it. So this is the caudate lobe of the liver in longitudinal section, and here we are seeing it in transverse section. Again being bounded by, and this is being bounded by ligamentum venosum in transverse section. This is the fluid part, and this is these are the echoes that are seen within the cystic mass relating to the segment 1 or caudate lobe of the liver. There it is. Now this is pathology number 1. Another thing, if you see, you will see that there is intrahepatic bile duct ectasia, and the bile ducts are dilated minimally, though not significantly, but you can see that there is dilation of the bile ducts along with this. Now in this scanning plan you can see both. This is the caudate lobe cystic mass, and these are the mildly dilated intrahepatic bile ducts. This is the liver, and now we see that the pancreas is normal. This is the pancreatic band. This white band is the pancreas. This is splenic vein. This is mesenteric artery. This is the aorta. So the head of the pancreas, this is the head of the pancreas. Again you see the pathology of the caudate lobe. This is the aorta. This is the superior mesenteric artery arising from it. These short segments again shows intrahepatic bile duct ectasia. Now this is the head of the pancreas in longitudinal section. This is the portal vein. Well, that is the reason I always stress that one should be as perfect as possible in the study of normal ultrasound. The better you know the normal, the better you will be reporting the pathologies. So knowing the normal is very important in such cases. Massage. Asking the patient to turn to left lateral decubitus posture to evaluate the common bile duct, which is important, in all such cases. Okay. This is the portal vein. This is the hepatic artery in transverse section. This is the common bile duct, and the common bile duct measures 8.3. This is mildly dilated common bile duct, because up to 7 is considered normal if you see the gallbladder is present. Now this is the portal vein again. hepatic artery, common bile duct running anterior to it. This is the area. This area is that of the porta hepatis. This is the porta hepatic region. No lymph node is seen in this region, and mild dilation up to 8.3 is seen that of the common bile duct, whereas 7 is considered to be normal. And moreover, what we see is that the gallbladder, these are the echogenic areas that you are seeing in the gallbladder, which shows muffled walls. These are the calculi within the gallbladder. Now the gallbladder shows muffled walls. This is the portal vein, common bile duct. This area is representative of the CBD, common bile duct, and if you note, there are echogenic areas within it, and these echogenic areas are giving posterior shadow, sharp posterior shadow, and are consistent with calculi. However, the wall of the gallbladder is muffled, and this is the liver. Liver shows fatty changes as periportal echoes are seen decreased. This is the portal vein, and this is the common bile duct in this patient. So in this particular location, the CBD measures 8.1, so at the upper limit of normal, not significantly high. This is the second pathology, cholelithiasis, dilated bile duct, mild intrahepatic bile duct ectasia, and there is fluid seen with echoes in the Morrison's pouch. Now this is the Morrison's pouch, and you can see fluid with echoes in this. This is the fluid between the liver and the kidney. Kidney is normal. Noted, kidney shows no pathology. So this is fluid in the Morrison's pouch. This is the fluid in the. I'm showing you a magnified view now. There is on the right side, we do see small amount of fluid in the right pleural space, which is consistent with minimal pleural effusion. Here we are. This one, you see. This is the diaphragm, and you see fluid above it. This is minimal amount of fluid in the right pleural space. In this patient, this is the fluid in the Morrison's, in the hepatorenal angle leading towards the Morrison's pouch kidney. So there it is. What is the status on the left side? Now if you see, there is a very small amount of fluid left seen in the left pleural space as well. It's a very small amount. See, this is the fluid, these are the gases within the left pleural space. This is the spleen. Spleen is not enlarged. Left kidney is normal. There is no ascitic fluid seen in this patient. So there is no evidence of para-aortic gland enlarged lymph nodes. There is a small paraceliac gland enlarged lymph node seen with the central dot. This is a small paraceliac gland enlarged lymph node, small, and this central dot, white dot, is represented, suggestive of the fact that it's of benign nature. Aggressive lymph nodes do not show this. Now I have given a sweep to the probe to show you that it has not changed the shape significantly, and here we see this is the lymph node, tiny lymph node. So this is our case of the day that relates to the caudate lobe of the liver, the gallbladder, the obstructive jaundice, the muffled walls of the urinary of the gallbladder, and bilateral, very small amount of minimal rather fluid in both spaces, and this cystic mass that is relating to the caudate lobe. This is the caudate lobe of the liver, and the IVC is closing posterior to it. This is the ligamentum venosum that is seen anterior, bounding the anterior boundary of the caudate lobe. This is the fluid part. This is the echogenic area within the cystic mass of the caudate lobe that is of infective nature unless proven otherwise. This is the transverse section of the same, and this is the longitudinal sections. Thank you very much.